Hello, and thanks for joining us for a Cardiometabolic Conditions webinar on the Bioconcepts Education Centre. My name's Becky Carbines. I'm a naturopath and I'm here with the Bioconcepts technical support team and a writer for the Bioconcepts Education Centre. And today we're looking at the connections between micronutrient deficiencies, oxidative stress, and cardiometabolic disorders, because it's an area that I'm really passionate about, and I know that practitioners are also passionate about. There's just such a huge aspect of roles that we can play in nutrition and health and lifestyle that can really improve the quality of people's lives with these conditions. So going over today's webinar, we're really looking at an overview of cardiometabolic disease, and how it impacts our patients in clinic. We're concentrating on cardiovascular disease and diabetes type 2 today, just for the scope of this 1-hour webinar. Looking into some research on novel micronutrient interventions in cardiometabolic conditions. We'll also do some kind of recapping the connection between adipose tissue and adipokines, and clinically where you're looking at treating, and for that we're focusing on leptin and adiponectin, and also looking at lifestyle and diet risk factors and recommendations, really putting it all together, especially since lifestyle and diet really is a gold standard part of the treatment of cardiovascular disease and diabetes, and it's really important to inspire people to get inspired themselves about what you put on your plate, how you eat, what your relationship with food. We'll talk quite a lot about that because it's something I'm really passionate about. So what and why am I super passionate about this? I've had 6 deaths in the last decade in my family from cardiometabolic disorders, including different types of cardiovascular disease and diabetes type 2. So it's very real for me, and I'm sure it's real for you who's listening. There's probably no one untouched. It's one of Australia's largest conditions that has a massive death toll. So definitely it's a major player in our clinics and in our society. And obesity is no longer just a health problem, but it's also an economic problem for our community as well. So it places an enormous financial burden on our healthcare system. This statistic, in the next 20 years, obesity-related illness will make up around 16% of the total healthcare cost in Western countries. And isn't that reflective of what we see here in Australia? It's ubiquitous, it's everywhere, it's overwhelming, and it's consistently increasing. So cardiovascular disease is a group, certainly an umbrella term, that includes diseases of the heart, stroke, and blood vessel diseases. And it kills 1 Australian every 12 minutes. 12 minutes, it's just mammoth. So cardiovascular disease was the main cause for almost 500,000 hospitalizations in Australia in 2014-2015. This were the best statistics I could find, closest. And it claimed the lives of over 45,000. That's nearly 30% of all deaths in Australia in 2015, and they're deaths that are largely preventable. And that's, I think, if anything we can take home from today's webinar, and anything that I'm majorly passionate about, is the fact that these deaths are preventable. We can do something about them, and we can get our patients inspired to change their lives and their family's life for the better. Lower socioeconomic groups, Aboriginal and Torres Strait Islander people, and those living in remote areas had the highest rate of hospitalisation and death resulting from cardiovascular disease in Australia. This is really relevant, but also kind of remembering that lower socioeconomic group doesn't need to be in an Indigenous population or in a remote community. That can also be in an urban community as well. So look out for that too. Coronary heart disease certainly is a massive aspect of cardiovascular disease, and it's the single leading cause of death in Australia. kills one Australian every 27 minutes. So this is stuff that might not be seen. You can't see inside someone's heart when they come into your clinic, but this is really high statistics here, and you know that people are impacted by this, and there's risk factors for that to look out for when patients come and see you. So you've got different types of risk factors, and certainly if I were to come see you in clinic, my family history of premature cardiovascular disease is a big one. It's a non-modifiable risk factor that I have. Family deaths under 50 for cardiovascular disease and heart attacks, but also age and sex. If your patient's a 61-year-old man, they can't change the fact they're a 61-year-old man. Or things like social history, including cultural identity, ethnicity, and socioeconomic status. This kind of makes up their epigenetic profile as well. Pardon me. What we're really, really excited about are things like modifiable risk factors, things like how nutrition and their lifestyle can affect their blood pressure, their cholesterol levels, serum lipids, waist to hip ratio, and BMI. Also with counselling and definitely nutritional support, you can look at getting them off alcohol, getting them off smoking, really important things that from a nutritional perspective, we can help them to reduce. And other related conditions that I find myself talking about on the phone quite a lot are type 2 diabetes, chronic kidney disease, and familial hypercholesterolemia. So these are things that you see in clinic all the time: diabetes, chronic kidney disease, and high cholesterol. Certainly evidence of atrial fibrillation or any sort of heart problems to begin with is something to really keep in mind, but often people won't present with history of a heart condition. They can have cardiovascular disease incidences from no history at all. So remember that, and look out for those non-modifiable risk factors and modifiable risk factors. Certainly we can really concentrate on things that have already been diagnosed, but a lot of the time cardiovascular disease doesn't get diagnosed before it kills. Diabetes. And this is something I'm really passionate about because it's one of the biggest challenges that is really coming up against Australia's healthcare system. Around 1.7 million Australians have diabetes. And that's a really, really huge percent, considering we're quite a small population. That includes all types of diagnosed diabetes. There's 1.2 million known and registered. But Diabetes Australia are actually estimating that there's up to 500,000 people with undiagnosed and untreated type 2 diabetes, which is extraordinarily serious. To have long-term undiagnosed and untreated type 2 diabetes, patients are at a higher risk of having comorbidities and an increased rate of damage to microvascular injuries of their eyes, of the kidney damage, and of peripheral neuropathy. So it's really important to keep an eye on that. If you think you have a patient who's at risk of having type 2 diabetes, they need to get tested immediately. Because 280 Australians are diagnosed with diabetes every single day. That's one person every 5 minutes. And it is the fastest chronic condition in Australia. More than 100,000 developed diabetes in the past year. So this is mammoth, and it's something that you might not know you're seeing in clinic, but you should definitely be looking for both these conditions, type 2 diabetes and cardiovascular disease, hang on the fringes of our society when they are actually there, right in the mix of it, often not diagnosed until it's too late. Type 2 diabetes is something that we can really keep an eye on, and I like this little chart. It's certainly handy for people to relate to. You're looking at patients who always feel hungry, extreme fatigue, frequent urination, and always thirsty. So of course that can be a lot of us. So it's good to ask more questions. Are there any unexplained weight loss? Do you have numb or tingling hands and feet? And then look at any complications. So type 2 diabetes really results from those pancreatic beta cells not being able to produce enough insulin to compensate for an increasing insulin resistance. And this happens through a bit of a pathway here. In the early stages of the disease, what happens is your pancreas beta cells start functioning really hard. They increase their mass and start producing lots of insulin to compensate for that insulin resistance. So they work, and then over the disease progression, all that working creates huge deterioration of the beta cell function and mass, partially due to that accelerated apoptosis. So it just can't deal with that demand placed upon them. The main factors contributing to the loss of pancreatic beta cell function and mass are that high blood sugar, that glucotoxicity, lipotoxicity, high cholesterol, and lipid peroxidation kind of goes with that, and islet cell amyloid. And it's really important for the maintenance of beta cell function and mass. They're really huge clinical goals you want to keep in mind. You want to be protecting the pancreas and supporting it. And we'll talk about that with nutrients today, because that's what we're all about. Nutrient interventions are something to get people inspired about, especially on a food as medicine level. I love that food is our medicine and our medicine is our food. And often people who do have cardiovascular disease or diabetes, it's really just something that has become a lifestyle habit, a poor lifestyle habit, and really re-educating them about foods. And it's what we're good at. I feel like allied health professionals, and that includes a whole list of, nutritionists, naturopaths, herbal medicine, acupuncture. We have a very, very good standing on knowing what good whole diets are and how we can implement them with different lifestyle choices. And when we talk about antioxidants, or when we talk about nutrient interventions, we're really going to talk about antioxidants. And what does that mean when it comes to cardiometabolic conditions? This was a study in 2016 on the relationship between lipid plasma antioxidant vitamin levels, adiposity, and the cardiometabolic profile in adolescents that are in a weight loss program. And the study was really looking at what levels were the antioxidants at in plasma, what levels were the adolescents' adiposity, and then how high their cardiometabolic risk was over the time of that weight loss program. So what they did was they tested plasma concentrations of your alpha tocopherol, retinol, beta carotene, and lycopene, all beautiful lipid-soluble antioxidant vitamins. They also looked at anthropometric indicators, of central and general adiposity. So looking at those skin folds, measurements, as well as blood pressure and blood tests. And they found that in adolescents, the increase in those lipid antioxidants, alpha tocopherol, retinol, and beta carotene, that was highly associated with a reduction in adiposity and a clinically significant improvement in those cardiometabolic profiles, which is really important because when you're an adolescent, it's important to get on top of a cardiometabolic profile. So where their cardiometabolic risk was, they found that the adolescents that were higher in antioxidants ended up losing more central and general adiposity, so weight loss, as well as having that improvement in the cardiometabolic profile. That was really positive for them, and they found that increasing lipid-soluble antioxidant vitamins and carotenoid levels could be really useful in childhood obesity treatment, very healthy, low toxicity, not worried about overdosing on those vitamins. as much. And since lipid-corrected alpha-tocopherol, beta-carotene, and lycopene were related to greater weight loss, they're really recommending further research. So good news from that study. Also, great news from a very comprehensive European prospective investigation and vitamin C and stroke incidence. So I remember this was the first antioxidant I'd ever heard of in primary school when people came out on ships and they'd take oranges to stop scurvy. Vitamin C is such a huge antioxidant. So this was a population-based study of over 20,000 men and women over a 10-year period. So very comprehensive study, and it was with men and women aged 40 years to 79 years, and none of the people had stroke at that baseline. So they excluded anyone that had a history of stroke or cardiovascular disease. And what they looked at was really thorough questionnaires, their height and weight, and their body mass index, as well as blood pressure and blood tests as well. So over that 10-year period, and the 20,649 participants, they had a total of 448 incident strokes over that 190,000 total person year follow-up. So huge comprehensive study. And they found that higher levels of ascorbic acid were associated with a reduced cardiovascular disease risk. So they showed over the period of that study that individuals in that cohort, if they had a higher vitamin C concentration and they were in that higher concentration quartile, they had a less incident of stroke and cardiovascular disease. P-value of 0.0001, so very significant. You can see that just on the column closest to the left is the one's lowest, and the column closest to the right, apart from the p-value, is those highest in vitamin C values. You can see those lowest had a much higher rate of myocardial infarction, 253 incidences of heart attack to 82 incidences. So huge. Same goes for prevalent diabetes. 3 times the amount of people had diabetes as opposed to only a third. Very promising. So that huge European prospective study was really based on cardiovascular health and that stroke incidence, but vitamin C status is also highly researched in diabetes as well. And it's really that antioxidant level. So this was vitamin C's association with glycemic control, obesity, and smoking, which are all really important things. This was an article published in Nutrients Journal, and they found that there's evidence to suggest that people who have type 2 diabetes have lower plasma concentrations compared to those with a normal glucose tolerance. So they looked at a normal glucose tolerance group, pre-diabetes and diabetes, and saw that those in the normal glucose tolerance group had a much higher amount of plasma vitamin C concentrations. And there's a couple reasons why they think this is a mechanism. They found that patients with type 2 diabetes have increased ascorbate excretion, who have microalbuminuria. There's also the fact that blood glucose can compete with vitamin C for the uptake into cells due to structural similarity to its oxidized form. And also, type 2 diabetes in itself is an inflammatory, and certainly obesity is a chronic low-grade inflammatory disorder. Increased oxidative stress will certainly deplete your antioxidant stores, so just absolutely, go through that vitamin C quickly. And chronic low-grade inflammation and oxidative stress really do play a pivotal role in the development of insulin resistance and type 2 diabetes to begin with. They found in their study that individuals with a higher weight are also prone to vitamin C inadequacy and are known to require higher intakes of vitamin C in order to reach adequate plasma concentrations. And this can be due to a couple reasons, especially since vitamin C is highly absorbable, but it's also highly excretable. Also, depending on the diet, people who sort of stereotypically have a very Western diet aren't going to be getting high levels of vitamin C in it. So looking at this study, same one, this was a graph looking at that normal glucose tolerance group, pre-diabetes and type 2 diabetes mellitus. And you can see that patients with pre-diabetes and type 2 diabetes had a much higher level of inadequate vitamin C status, and they need even a higher amount of that adequate and saturating to compensate for the added oxidative stress as well. So just keep that in mind, because vitamin C is such an important part of treatment protocol. Another favorite antioxidant, glutathione. I love glutathione, and this study on glutathione peroxidase in type 2 diabetic patients. And it's really important to think about how antioxidants go from an antioxidant to maybe a pro-oxidant, and that redox reaction, and how prolific that can be when a patient's in a state of low-grade inflammation, chronic low-grade inflammation, and oxidative stress. So they found that red cell glutathione levels were significantly lower, so they had a much lower levels of glutathione in all types of diabetes compared with age-matched normal control subjects. Whereas that glutathione peroxidase activity was found to be significantly increased in poorly controlled type 2 diabetes and type 2 diabetes with coronary heart disease. So there's a few mechanisms of action that this can happen, but certainly chronic hyperglycemia, so chronic high blood sugar, can initiate the formation of free radicals, your superoxide, which then can be converted into hydrogen peroxide by enzymes. Glutathione peroxidase and catalase can then convert that hydrogen peroxide to water, and then glutathione just gets chewed up in this final step, leading to that reduced levels of glutathione. So you're losing other antioxidants, not just vitamin C that gets chewed through, but glutathione also. On top of that, they also found other mechanisms that are really important to look at. They found that increase in glutathione peroxidase activity really made a higher consumption of your glutathione, but also glutathione is regulated by an enzyme, glutathione reductase, which uses reducing equivalents from activated B3. So NADPH. NADPH is generated in red blood cells through a pentose phosphate pathway, and that pathway is stimulated by insulin. So obviously in type 2 diabetes, that pathway is thought to be really sluggish, resulting in a lowered glutathione reductase activity and less glutathione recycling. Also in type 2 diabetes, sorbitol synthesis is higher, causing an NADPH depletion. So you're also looking at supplementing with nicotinamide. So something so simple like that glutathione recycling is really important. So supplementing with B3 or B vitamins is really, really essential for that glutathione regeneration. Wrapping up my antioxidants for today, vitamin E is one of my favorite antioxidant, and it has great research with cardiovascular disease and diabetes and other markers, but certainly vitamin E is involved in so many biochemical processes, and it's certainly an electron donor activity that supports membrane integrity in the body tissue, and provides protection from lots of oxidative stress. And I love now that research is really concentrating on all of the 8 isomers of vitamin E as well. For so long, alpha tocopherol was the only, it was the golden child. So really more and more research is coming out about the other 7 isomers, your tocotrienols and your tocopherols. And there's several studies that really look at how Y tocopherol plasma levels are indicated in cancer and cardiovascular disease risk. So this was in a 2017 study. This study saw that higher plasma Y tocopherol concentrations correlate with an ameliorated inflammatory response. So the higher those levels, the better your body will respond to inflammation. And this is reflected by a reduced response of pro-inflammatory chemokines, which is really important. The study also found that vitamin E was really clinically relevant for overweight and obese men with low-grade inflammation who can have that elevated risk for the development of type 2 diabetes and complications thereof. So that's really, really essential, because clients with type 2 diabetes, as they escalate, will have complications with their cardiovascular disease, kidneys, eyes, and peripheral vascular system as well. Lycopene is one of my favorite food as medicine targets, especially in clinic. It's get out your tomatoes and a little bit of olive oil and make that beautiful fresh pasta sauce. Vitamins and carotenoids are such key ingredients in antioxidant profiles in general, but lycopene's really reported in this 2017 study published in Genes and Nutrition. They showed research to report that lycopene's really related in eliminating that reactive oxygen species, inhibiting lipid peroxidation, and reinforcing the immune system. And that's really important for cardiovascular disease and diabetes, because they're 3 huge clinic goals to look for. You're really looking at decreasing oxidative stress in general, supporting healthy lipid metabolism and reducing lipid peroxidation, and focusing on supporting a healthy immune system. They've also spoke that higher serum concentrations of lycopene have been associated with a higher survival time among participants with metabolic syndrome. And wrapping up our micronutrients in cardiovascular disease and diabetes before we move on to adipose tissue and lifestyle, vitamin D is so important. There's such a vitamin D deficiency going around the world. It's here in Australia quite prolifically, and there's quite a strong correlation between individuals who are vitamin D deficient and having a higher risk of cardiovascular disease, risk of diabetes and metabolic syndrome. And there's a few theorized mechanisms of action there. No concrete reason, but certainly there are many potential reasons why vitamin D is so important to the cardiovascular system. Certainly there's an immune, there's the downregulation of this renin angiotensin aldosterone system, how that has direct effects on the heart and vasculature, and also the improvement of glycemic control. Vitamin D also has an impact on your immune system, and vitamin D is also a really important prohormone for that calcium absorption back into the bone. So mineralization of bone depends on vitamin D, or certainly an aspect of it. And because vitamin D receptor is present in lots of tissue, there's been interest in evaluating potential functions of vitamin D with that cardiovascular disease risk. And when people eat calcium, it's important that it does mineralize the bone, rather than floating around and calcifying cholesterol deposits in arteries. So you want that calcium back into your bone rather than, forming atherosclerosis. Vitamin D is so important. And moving on to the next section of our webinar, Adipose tissue and adipokines is a really fascinating. Certainly, this could be a webinar in itself. So we're just focusing briefly on some really clinically targeted, so really presentations that you can use in clinic and support adipokines like leptin and adiponectin. Because 100 years ago, we really thought fat tissue and central adiposity was just energy storage. If people ate too much, that energy store, it was just fat ready to go for energy. But now we know that our bodies are its own universe, and adipose tissue releases a large amount of bioactive mediators, adipokines, and it's its own endocrine system of hormones that modulate hemostasis, blood pressure, lipid and glucose metabolism, and atherosclerosis and inflammation. So on the right hand side you can see a little diagram with all these adipokines. So you've got quite a range of them. It's really important to know that these are all modulated and healthy at some point, but certainly in the state of obesity, that chronic low-grade inflammation and higher levels of oxidative stress, these levels, when they go out of whack, suddenly they potentiate and create a pro-inflammatory network and cascade. So at first, as we discovered the adipose tissue, fat cells, little adipocytes, produced these adipokines, we thought it was only restricted to an insulin-mediated kind of glucose uptake. But more and more we see that there's pro-inflammatory adipokine profiles in obese adipose tissue as opposed to sort of normal adipose tissue that contributes to pancreatic beta cell injury. And the induction of that beta cell injury by apoptosis is really seen through adipokines like interleukin-1, TNF-alpha, and INF-C. And I mentioned like normal, healthy fat tissue. We all have adipocytes. It's very normal. And you can see in the little diagram to the right, you've got a healthy little adipocyte. Certainly there's a pathway, that cascade to metabolic condition that flows. So certainly in an increased chronic inflammation state, you're looking at those adipokines changing. So and there's an increase in your TNF alpha, and it stimulates these little pre-adipocytes to produce a attractant protein. So that's the monocyte chemoattractant protein, and that protein attracts increased macrophage activity to the site. So that increased macrophage activity in adipose tissue and adipocytes leads to the impairment of adipocyte function, causing insulin resistance. This is this inflammatory state. Further cascade of the inflammatory cytokines interleukin-6, interleukin-1 beta, and TNF-alpha activate further JNK and IKK serine kinases, which promote this phosphorylation and low-grade inflammation, insulin resistant, and ultimately metabolic disease follows. So it's really, and I know naturopaths often talk about healing the gut, reducing inflammation. Healing the gut, reducing inflammation. The reducing inflammation is so important here. So leptin, just a little bit of information on leptin and adiponectin. Don't they just roll off the tongue? Leptin was the first adipokine suggested to directly exert pancreatic effects. And this is really interesting because when leptin was discovered, they thought leptin was this wonder drug. It would be the drug to get people to lose weight. And now they see that it's not necessarily just weight loss, but it's also food cravings. It's a modulating aspect, so it can regulate glucose homeostasis by modulating the synthesis and release of insulin and glucagon through direct actions on the pancreas. And there's certainly conflicting. When it was discovered, it was meant to be this golden child to make everyone lose weight, but now people are seeing it's that modulating effect. So it's currently accepted that leptin inhibits insulin secretion in beta cells. Leptin has also been shown to inhibit ectopic fat accumulation, prevent beta cell dysfunction, and protect the beta cell from cytokine and fatty acid-induced apoptosis. So very, very great, important adipokine. Adiponectin, however, is an insulin sensitizing protein. So these receptors for adiponectin are found in your pancreas, in those beta cells, and it's really great for inhibiting apoptotic effects in the pancreas of that inflammation damage of the cytokines and palmitate, and prevents the impairment of insulin secretion induced by FFA and cytokines. So adiponectin also reverses apoptosis triggered by both intermittent and sustained high glucose. And that's really important because that's a big treatment goal, because you want to really reverse apoptosis in the pancreas that has happened because of that increase in blood sugar. It's really protective. Adiponectin positively affects beta cell function and growth. And I'm asked every day on the phone things about what's the difference between a pro-oxidant and an antioxidant, or an anti-inflammatory and a pro-inflammatory. But certainly adipokines have both pro-inflammatory and anti-inflammatory conditions, and it's really regulated by that chronic low-grade inflammation and oxidative stress that's going on to begin with. So it would be nice to be able to say that leptin is a perfect one that you would always want to increase, but certainly it's that real modulating effect as well. But how do you treat that in clinic? And certainly zinc is an amazing double hitter for leptin and adiponectin. So you get to hit two birds with one stone. Zinc's fantastic. This is a study on the effects of zinc supplementation on the leptin levels and BMI in a group of women that were going through a weight loss program. So there were 60 patients, and they were randomly divided into groups to receive 100 milligrams of elemental zinc or placebo for 60 days. And they saw that the mean serum leptin levels in the women in the experimental group was decreased significantly after supplementation. And this is what you would expect with the weight loss program as well, very positive. After adjusting for age, BMI, body fat, and serum zinc, a negative and significant association was observed between the leptin and zinc levels. There's a very strong interrelationship among obesity, leptin, and zinc metabolism. So physical activity that these women were doing with the weight loss program also changes leptin secretion, which in turn can be really significantly related to zinc. Adiponectin and zinc, however, have an insulin-like effect. So this was shown through a study assessing zinc supplementation and serum adiponectin and insulin resistance in first-degree relatives of diabetic patients. That's me. I'm a first-degree relative of a diabetic patient. Study was performed, and patients consumed in the treatment group 50 milligrams of zinc orally per day for 3 months. And the other group was not given zinc, but recommended regular exercise and weight control. The zinc group was found to significantly increase the levels of adiponectin, and that adiponectin is so important for that protective effect on pancreatic beta cells. And now into the final sort of subheading in our webinar today, diet and lifestyle. And I mentioned before that this is a really gold standard and a huge pillar of your treatment when you look at cardiovascular conditions, because they've shown over the past 50 years, that even longer, that suboptimal nutrition is a real leading cause of your poor health. And more studies these days are looking at whole food diets rather than single isolated nutrients, and recognizing the complex influences of different foods rather than just counting calories. It's really important. I speak in the next couple slides about the feasibility for people to completely change their diets, what kind of barriers they come across, and also how you're going to optimize that for the rest of their life. You want to educate them on how to change their health and their family's health for good. But before you change it for good, you really want to strike out some of those risk factors that would increase their risk of cardiovascular disease and diabetes. Things like smoking, obesity, and exercise are really huge things to look at just from the get-go, of course. And it's really a single, like smoking is such a huge potentiator of oxidative stress and disease, and certainly would stimulate the immune system further. In 2014, 2015, 1 in 7 Australians aged 15 years and over smoked daily. I hope that's been reduced. So that's a little bit of older numbers. Unfortunately, I think the next two have increased. Since 2014, 2015, close to 2 in every 3 adult Australians aged over 18 were overweight or obese. So that's over half the population, over 60% of the population of adult Australians are overweight. And as clinicians, I wouldn't say that every single person that I've treated, or even 60% of the people I've treated for weight, or looked at their weight and really encouraged them to change their diet and lifestyle from the get-go, just from that. But it is something that, as our society is more and more westernized now, it is increasing. This statistic is increasing. We should be looking at promoting healthy eating in every person, regardless of their weight. Also, in 2014, 2015, around 2 in every 3 adult Australians aged over 15 do very little or no exercise at all. And I see this reflected in so many people, certainly during the week. I know I sit at a desk for 40 hours a week. I have to push myself to get out there with the dog. I know my dog's been a massive help for me to do extra exercise and get out there and pound the pavement. But with more research coming out lately, especially you've probably seen it on social media, that sitting will be the new smoking of the next generation. Sitting is a major problem for our Western society, and definitely getting out there, doing active exercising, living active lives is really a huge part of what made Homo sapiens work. We weren't meant to be immobile. We were made to forage and collect, made to be active. And I mentioned before that looking at diet and lifestyle, it's so much more than calorie in, calorie out. Talking to people on that level will affect some group of people, certainly. If you've got type A personalities in clinic who really need to be given a goal, and that's how they work, perfect. That's the kind of thing that you can work with by counting calories. But people are so much more complex than that, and we see that every day in clinic, seeing patients that develop cardiovascular diseases and cardiometabolic diseases like type 2 diabetes. It's a chronic lifestyle disease. It's happened through a lifetime of poor choices that can be made out of apathy, can be made out of enjoyment, and it's really about examining why those choices were made, and looking at, is it their food access? Is it their taste? Is it their palatability? Is it just what they enjoy? It's certainly things like, do they have impaired satiety signaling or insensitivity to hunger? So could it be like a biochemical kind of genetic aspect to it? Or is it just advertising, environmental influence, things like their work? Do they work shift work? Are they exhausted? Do they watch TV while they eat and not really notice they've eaten 2 whole plates before they finished? And last year I had a really complicated case of food addiction. which are one of the hardest clients I've ever treated. And often if you treat someone for heroin addiction or cocaine, the goal is to get them to not take the drug they're addicted to. But individuals with food addiction still have to eat. So it's very, very complicated. Again, is there that aspect of reward sensitivity or dopamine pathway to look at too? So good to kind of see where it is that your client or patient really resonates with. This is a great little diagram. All the food they eat, and I like to show this to patients, all the food they eat influences every part of their body. It's not just their weight. So often when patients come for weight loss or cardiometabolic conditions, they just want to lose that central adiposity. They're not thinking about how their food has an impact on their mind or their gut microbiome or their adipocyte function or vascular adhesions. They're really just looking at how do they reduce that fat. But we think as the whole person, and that whole Western diet that a majority of our population eats is very poor. Re-educating all about that. And certainly Mediterranean diet and or a sort of like a slightly altered one depending on your client, especially if they have food sensitivities or allergies or IBS certainly. But anti-inflammatory Mediterranean diets have repetitively over and over and over again shown the benefit of a Mediterranean diet in cardiovascular disease. They've shown that a greater adherence to that Mediterranean diet is associated with a lower cardiovascular disease incidence, and that an adherence to a Mediterranean diet is associated with an increase in serum markers of atheroma plaque stability. So that's, in one part, a reason why the Mediterranean diet can be protective against heart attacks. And also there's consistent evidence that a Mediterranean dietary pattern is an effective and feasible tool for the prevention of cardiovascular disease. Same goes for diabetes. And I was talking with someone before about things like keto diets and other kind of, I've certainly seen keto diets work quite well in fast weight loss. Often they can put the weight back on if they haven't changed their lifestyle. It's important to remember that adherence to a Mediterranean diet is the important, or like any diet really, a great healthy diet full of fresh greens and vegetables, low refined grains and sugars is really important. But they also saw in this that there was a higher adherence to the Mediterranean diet was associated with a 23% reduced risk of developing type 2 diabetes. And again, the study down the bottom showed that adherence to a Mediterranean diet was associated with greater treatment satisfaction in patients with type 2 diabetes. The slide above mentioned feasibility. It's not a sprint, it's a marathon. These people are changing their whole lives for the better, changing their families' lives, and it's really, call me a lazy naturopath, but it needs to also be something that they enjoy. It's not something that they can do for only 6 weeks and get over. It's a complete change of how they eat and what kind of foods that they choose to eat. And there's barriers to this change, whether it be what foods they like. They just really like refined sweets, kind of like that sweeter taste or that fatty taste, or even where they work or who they live with. It's quite huge when it comes to the barriers for healthy eating. And it's important to look at where your patients can have barriers in their own lives and then talk to them about those barriers. This is a great evidence-based approach for individual behavior change in clinic settings, in a pretty amazing article, The Dietary and Policy Priorities for Cardiovascular Disease, Diabetes and Obesity, a comprehensive review in 2016. But they really spoke about this table and how it's really important to promote that individual behavior change, and these are some aspects that clinicians can do to support that. And we do quite a few of these, but I've added more examples of the self-efficacy and motivational interviewing because I found them really interesting. But in clients, it's really important to support specific proximal and shared goals. So really look at setting goals that they can achieve quickly so that they feel a sense of mastery over their situation, so that they can feel confident in their steps that they're taking to change their life. We certainly are really quite on top of self-monitoring. Things like diet diaries are really important. However your patients choose to do diet diaries, whether it be a physical kind of diary or whether it be on their phone or web app like thing, and follow-ups and regular feedback. But talking to your patients about their self-efficacy and increasing their perception that they can successfully change their behavior is something that is really important. And there's so many ways that you can do this. Just on the right-hand side, whether it be that you set that close goal that a person can successfully achieve, or you can inspire them through vicarious experiences, getting them to hear a story or, connect with someone who's going through a similar thing that they're doing. If they can do it, so can I. That deep feeling of camaraderie and relatability is important so that they feel like they're not alone. Explaining the physiological feedbacks so they know when a change in their symptoms is related to a worse or improved behavior. We do this quite commonly in cases of IBS, or I had a patient who went on a cruise ship and had a cheese platter who had bad IBS, and he reported extraordinarily painful symptoms after that cheese platter. That's certainly a physiological feedback reaction. And verbal persuasion. So you want to really persuade your patient that you believe in your capacity to perform that behavior. Whereas motivational interviewing is that little bit deeper, examining why perhaps the patient may feel ambivalent towards changing their life circumstances. I know in my family, and I'm sure everyone listening can really relate, some people feel like it's too hard to change what they've been doing for the last 30 years. And that's common to believe, like, why change, especially if they have a family history of cardiometabolic conditions. Like, I've heard individuals say things like, oh, well, my dad had diabetes and he ate whatever he wanted, he just changed his medication. Oh, that's not really what we want. And explaining and educating them about that, but also seeing like what is that root feeling towards their ambivalence, or the reason why they don't want to change, why they're resistant to changing the barriers to a healthy life and healthy lifestyle. So whether that be just seeing if it's something that you can sort of inspire, or whether that be something quite deeper. So certainly in getting them to eat healthy food, it might just be they don't like the taste and it's education on how to cook. But others I've heard quite deep and tragic reasons why they might gain weight as a barrier against things that could come to childhood trauma and things like that. Referral to psychologists are really important here as well. Use that team, whether that be diabetes educators, doctors, psychologists, exercise therapists, really important. And also family and peer support. Any diet like this, especially a huge one, is definitely a whole family affair. So wrapping up, so many articles are now really seeing that it's that Western diet is now the cause of prolific, chronic, low-grade inflammatory disorders and oxidative stress that contribute to diabetes type 2 and cardiovascular disease. The great study that I mentioned in the previous slide also recognised that margarine is the worst and should be well and truly down the bottom, closest to the harm arrow. And they said that red meats should be minimised. Butter could be used occasionally, but not necessarily emphasised. Fair enough. And other foods like unprocessed poultry, eggs, could be consumed in moderation, according to personal preference. So not necessarily demonizing eggs or butter. So slowly but slowly, that whole food diet, really concentrating more on fruits, nuts, fresh vegetables and fish, whole grains, is really, really that where you're heading. So things to remember as we wrap up today: cardiometabolic diseases are so common. Cardiovascular disease kills one person every 12 minutes, and one person is diagnosed with diabetes every 5 minutes. It's miserable. The statistics are miserable, and they're people we see every day in our life, certainly in our clinic, and we can change their life. We can optimize it, make them feel better, get them inspired about food, and get them inspired about connecting with their vitality. Really, for a goal, you were looking at changing their lifestyle and diet, definitely. And it's hard for people. It's really hard, but it's worth a push. Also, for the sake of this 1 hour webinar, we've only concentrated on micronutrients and diet and lifestyle, but also you're really always treating the whole person. Look into those comorbidities, things like sleep. Do they have sleep apnea? Do they have poor sleep just in general? Is that leading to an increased amount of stress, increased amount of craving food? Look at their mental health, whether that be through a dopamine reward pathway and they crave food, or even things like depression and anxiety, unrelated to even obesity. But is it unrelated, especially if there is chronic low-grade inflammation? Mental health doesn't get enhanced by chronic low-grade inflammation. And things like gut health as well, microbiome status, even just in general, looking at decreasing systemic inflammation is important too. We've got resources on different information as well for cardiometabolic conditions. This is all about herbs more than micronutrients on our bioconcepts.com.au. Great chart that goes through elevated HbA1c, insulin resistance, obesity, non-alcoholic. Is so much information, and the adipose axis. So there's 2 charts there together in the same bundle. Check it out on our website. If you have any questions, please feel free to contact us here at tech support at bioconcepts.com.au, or you can call us direct on 1-800-077-113. We're here every day, Monday to Friday, ready to take your call. And thank you for joining us here today at the Bioconcepts Education Centre for our webinar on cardiometabolic conditions. I really appreciate your time. Thank you.